Oh, sorry. I was just asking, do you find the timing? We're trying out this new timing, which is spread over a week with most of the sessions in the evening. Do you think that is helpful, or would you rather have the more conventional 9 to 5 Congress?
I think this is helpful.
Yeah, this is good because we can yeah, log in the evening.
Yes, because I was thinking most of us can at least maintain some level of clinical work during this week.
Yes, yes.
Yeah. It's just that if we have overseas speakers, then it's difficult. Like during the YO symposium, we invited people from SOE and AAO. Yeah, the time is a bit odd for them.
I see. Because after the Congress, we can always discuss further and review the whole arrangements so that in future we can learn from this experience.
Yeah.
But hopefully next year, we'll have a physical Congress.
Yes.
We hope so.
We hope so.
In Kuala Lumpur and also in Chengdu.
In Chengdu, sure.
Yeah.
Mm-hmm.
Yep, I can see that there are some chats already.
So the question now is Prim going to make it?
But knowing him, he's probably starting to prepare his PowerPoint in about 5 minutes' time. But I believe he'll be here. I believe he'll be logging in very soon.
I'm sure he will.
I think he will. I was wondering he had 2 presentations yesterday, and I don't know whether it was live, but it looks recorded to me.
Oh, is it?
Mm.
Do you know, Claire? Do you know whether Prim presented live or had a pre-recorded lecture yesterday?
Actually, yesterday he sent a message to Helen saying that he will do the recording last night, but until today we haven't received his recording yet. So either we assume he will make the live today, hopefully.
But he had some lectures yesterday as well. Is that correct?
I think so. Yeah,
Yes,
but
do you know what happened?
Yeah. I think they all receive it. I think that's okay, no problem with it yesterday. However, we have no idea about today.
Okay.
Because it looks pre-recorded. It looks pre-recorded.
Yeah. So somehow we're still waiting for his reply.
All right. Yes, I've just changed my virtual background. So Norman is actually using the latest Zoom background, while Sankang and we are using the old one.
Oh, okay. They look basically the same. Yes.
Almost the same, yes,
Yes.
true.
Yes. How is the weather in Hong Kong today?
It's very hot.
Oh,
It's very
hot.
hot over here.
Right.
And in fact, there are chances of a typhoon coming in the next couple of days.
Yes, because it's here now.
Yes,
so
it's heading our way.
Correct. So I am hoping that,
How is it at where you are now?
Well,
is it
right now it is just continuous rain, but not very strong.
I see.
The winds are also not so strong. So that's good. It's not your typical typhoon that we have, but there are 2 right now inside our area of responsibility.
Yes, I know.
Yeah.
Because either one could be affecting Hong Kong depending on their paths.
Correct. That's why I had to ask, how is your weather?
Today is still very bright and sunny. And in fact, it's extremely hot today. It's very, very hot.
I see.
But we're anticipating some bad weather from tomorrow onwards.
Cynthia is asking to start.
Okay. First of all, I would like to extend my warmest welcome to everyone attending this symposium. Angle current glaucoma remains a major cause of the irreversible blindness. We must have up-to-date understanding of all the latest laser and surgical options to tackle angle current and angle current glaucoma effectively and safely. Our APGS symposium will present the indication, technique, outcomes, and how to avoid and manage complication. For the whole lineup of the latest laser and surgical option for angle current and angle current glaucoma. The symposium aims to help ophthalmologists make the evidence-based selections, perform the laser or surgery effectively and safely, and offer patients the best possible clinical outcomes. We hope you would find the symposium informative and please enjoy the symposium. Thank you.
Good afternoon or good evening wherever you are. Welcome to the Asia Pacific Glaucoma Society Symposium entitled Laser and Surgery for Angle Closure and Angle Closure Glaucoma. I'm Dr. Seng Kiong Fang from Kuala Lumpur, Malaysia, and I will be talking on laser applications in angle closure and angle closure glaucoma. I do not have any conflict of interest in the laser and the devices presented. According to the Asia Pacific Glaucoma Guidelines, the third edition already published in 2016, under Section 2.3, laser treatment for angle closure and angle closure glaucoma can be divided into three. First is for pupillary block relief, which is laser iridotomy. Second is for modification of iris contour, which is known as iridoplasty or gonioplasty. And the third one is for inflow reduction, that is cyclophotocoagulation, and the traditional G probe is usually reserved for end-stage glaucoma, whereas now with the advent of the MP3 or the micropulse probe, we can use this modality earlier for cyclotherapy. Firstly, laser iridotomy. In the Asia Pacific Glaucoma Guideline, the laser iridotomy is used to relieve pupillary block because it is effective, it is relatively non-invasive, and is preferable to surgical iridectomy. And it communicates the anterior and posterior chamber and relieve pupillary block. What is the indication for laser iridotomy? In primary angle closure and primary angle closure glaucoma if the pupillary block is significant. Whereas for primary angle closure suspect, the absolute indication is when they have PAC or PACG in the fellow eye. And the relative indication is when there is confirmed family history of PAC or PACG, when patients need repeated dilated examination of the fundus, such as in patients who has diabetes, when there's patients have poor access to regular ophthalmic care, and patients that require medications that may provoke pupillary block, such as topiramate. With the advent of the ZEP study by Meng Guang et al. In Lancet 2019, it is not advocated for laser iridotomy for all patients with PACS, unless it is mentioned here in the relative indication. And the next indication is patients who have secondary angle closure with pupillary block, such as lens-induced glaucoma. If they do not have any pupillary block, such as in patients with secondary angle closure from uveitis, iris cyst, or uveal effusion, this procedure is not indicated. We can do laser iridotomy either by the YAG laser alone, or by argon laser alone, or a combination of the two. If you use YAG laser alone, you actually require lower total energy and less frequent closure of iridotomy, but they get more frequent bleeding. And this is easier for lightly pigmented and thin iris. For argon laser, we need a higher total energy. They get higher closure rate because of the smaller aperture, but bleeding is rare. So for pigmented Asian eyes, the recommendation is using both argon and yak laser. So the argon is prepare the bed, and as the argon is given, less energy is required just for preparation of the bed. And then when you open up with the yak, you do not get bleeding. So this is now recommended for pigmented Asian eyes with thick brown iris, which I will show you in the video in a short while. What are the pre-laser procedures? We instill pilocarpine to stretch the iris and constrict the pupil, topical epinephrine or brimonidine to prevent intraocular pressure spike, steroid eye drops post-operatively to control inflammation, and before the procedure, we use topical anesthesia. And if the cornea is edematous, such as from acute angle closure, we can use topical glycerin or hypertonic saline. What is the location and the size of the iridotomy? And the location, we have to do it as peripheral as we can, and usually now it's recommended to do it temporarily because of the paper published by Vera et al. In the AGO in 2014. But the main thing is to avoid the transection of the lid margin, because if you have the iridotomy transect the lid margin, then the patients can get visual symptoms such as diplopia. The final size of the iridotomy should be at least 150 micron, and we use the Abraham lens usually as is shown here. And if it's focused on the iris, it is the Abraham lens will make the spot size a bit smaller. So what is the parameters for the iridotomy? Initially, we do a preparatory or stretch burn in a shallow peripheral anterior chamber, such as later on I will show in the video, and the parameters are given here. And after doing the preparatory burn, we do penetration burns with a smaller spot size, less duration, and higher power. And I will show you again in the video later on. And for a dark and thick iris, we normally start with a shorter duration and higher power. For thick and blue iris, we start with a longer duration and lower power. But you need to modify parameters depending on individual response. And in the APGG, you can see the laser parameters in pages 45 and 46. And for yak alone, you need about 2.2 to 5 millijoule and 1 to 3 pulses per burst. But if you combine with the argon prepared bed of the iris, you need less energy, as I will show you in the video in a short while. Focus the beam on the iris stroma rather than the surface. And if bleeding occurs, wait with a gentle pressure on the eyeball with the Abraham lens. And the endpoint is to look for this pigment path, which I will show you in the video later on. So this is the video courtesy of Professor Paul Chew, and I will show you how the laser iridotomy is done in the combination with argon and yak laser. As you can see in this video, there are four categories of PAC mechanism, and this is indicated for the definitive treatment of primary angle closure. And normally, as I mentioned earlier, we use the Abraham lens. And on the slit lamp, we look for a crypts in the peripheral iris. And once you decided to do the laser, you normally will give a preparatory or stretch burns with a bigger spot size. So once you have demarcated the iris, then you use a penetrating burns, which is Normally 50 micron is spot size, 0.1 or 0.2 second duration, and up to 1000 milliwatt. And after preparing the bed so that they don't have bleeding, we will then change to a YAG laser. And the YAG laser, as you can see here, you do not need many shots, and mainly once you have the bed prepared by the argon laser as shown here, this is the first shot. You can already see the plume of iris pigments coming forward. And once you apply the second shot, the laser iridotomy will be patent. Next, I will cover laser iridoplasty. The indications of laser iridoplasty is to break the acute attack of acute angle closure, and especially if the cornea is too edematous to do a laser iridotomy, we will normally use laser iridoplasty to break the acute attack. And the second indication is when the angles remain occludable following your PI, such as in patients with plateau iris. And we can also use iridoplasty to facilitate access to the trabecular meshwork to do selective or SLT, trabeculoplasty, and also for as adjunct to goniosynovial lysis. I will show you the video courtesy of Professor Bob Rich, and this video will show that this iridoplasty is actually to apply burns that will stretch the iris. So the power setting is about 250 milliwatt, long duration 0.5, and spot size might be bigger than 500 microns. You may need to start nearer to the center first, especially in acute angle closure glaucoma. And when the iris is stretched and pulled away from the angle, then you can go towards the periphery, as shown here. The third laser modality is transscleral cyclotherapy. And in the APGG, the indications are failed multiple surgeries, failed multiple filtering surgeries, not or patients who are not fit or refuses surgery, or patients who have scarred conjunctiva. I will show you a video on the micropulse laser, which is on the left side of the screen. As you can see, the difference is in the laser probe is shown here, and also the application is slightly different, as I will show you in the video. So for the MP3 probe, after giving local anesthesia with either peribaba or subtenon's block, we apply sweeping motions in the pars plana or pars plicata. And normally this is about 10 seconds per hemisphere, and we apply with this probe 50 seconds per hemisphere with the G1 probe, which is the generation 1 probe. But we do now have the G2 or the generation 2 probe, which the protocol is actually 90 seconds per hemisphere. We can actually even do this without the speculum if the patient's palpebral fissure is too small, and we can actually do this procedure without speculum. But normally it can be quite painful, so you will need peribaba or subtenon's anesthesia. But I have done this with topical anesthesia as well, depending on the patient's pain threshold. Lastly, I would like to invite all of you to come to join us face-to-face next year at the 6th Asia Pacific Glaucoma Congress, which will be held 5th to 7th August in 2022 in Kuala Lumpur, Malaysia. Hopefully, by then, we'll be able to meet face-to-face. I would like to thank Professor Paul Chew, Professor Kiho Park, and Professor Robert Rich for their videos and their slides. Thank you very much.
Ladies and gentlemen, I'm Clement Tam from the Chinese University of Hong Kong. Welcome to this Asia Pacific Glaucoma Society APGS Symposium on laser and surgery for angle closure and angle closure glaucoma. In the next 10 minutes or so, I'll share with you the role of lens extraction in angle closure. Now, these are my financial disclosures and also the government funding that has supported our PACG research. Now, in the first part of my talk, I'll cover the role of lens extraction in primary angle closure, as well as primary angle closure glaucoma. And in the second part, I'll talk about acute primary angle closure. Now, it is not well known that lens extraction by itself dramatically deepens the anterior chamber, widens the drainage angle, and also improves IOP control in PACG eyes. In the next two slides, I will share with you my own management algorithm for primary angle closure disease. And in the first slide, we have a hypothetical situation in which 360 degrees of the angle is completely appositionally closed. In the next slide, I'll show you the other extreme end of the spectrum, when all 360 degrees of the drainage angle is closed by peripheral anterior synechia. Now, so first start with appositional angle closure. In this situation, in theory, if you can do something to widen the drainage angle, there's a possibility that aqueous outflow can be reestablished through a reopened drainage angle. And so you may not need any additional interventions such as filtration surgery for IOP control. Now, so in this situation, if there is visually significant cataract, you'll probably perform cataract extraction alone first. If there is still persistent appositional angle closure afterwards, which is most likely due to plateau iris syndrome, then you may consider argon laser peripheral iridoplasty. Whereas on the other hand, if there's no visually significant cataract, you may consider laser peripheral iridotomy. And after that, if there's still persistent appositional angle closure with ocular hypertension, then you would have to decide whether it is the lens or plateau iris syndrome being the main mechanism leading to angle closure. If it is the lens, then you consider lens extraction. Now, in the second hypothetical situation, when there is 360 degrees complete synechial angle closure, even when you have done something to widen the drainage angle, chances are that aqueous is still not able to access the trabecular meshwork. And in this situation, you may need some additional IOP lowering procedure to further lower the pressure. Now, if there is visually significant cataract, then you start off with cataract extraction with or without another IOP lowering surgery, which can be corneal synechiolisis, one of the cyclophotocoagulations, mixed trabeculectomy, or glaucoma drainage device implantation. Whereas if there is no visually significant cataract, then you would have to decide whether the lens is the main mechanism leading to angle closure. If it is, then you consider clear lens extraction with or without another IOP lowering surgery. Whereas if the lens is deemed not significant, then you may consider just performing one of these other IOP lowering surgery for this eye. Now, how do you know whether the lens is the main contributing mechanism to angle closure? I think from a clinical perspective, perhaps by far the most important sign is the central anterior chamber depth, which is the combined result of both the thickness of the lens as well as the anteroposterior position of the lens. So if the central anterior chamber is very shallow, chances are that the lens would be the main mechanism leading to angle closure in that particular eye. Now, another very important sign is what I would call the Mount Fujiyama sign or volcano sign. When you're looking at the front part of the eye, anterior segment of the eye from an oblique angle, if the lens is the main mechanism leading to angle closure, the iris as well as the pupil will take on the appearance of a volcano, with the pupil being the crater of the volcano. This is because of the draping of the iris over a very prominent, thick, and anteriorly positioned lens. And this particular configuration resembles the volcano even more when the pupil is in a relatively constricted state. Now, based on the above management algorithm, lens extraction will often be the first intervention of choice in primary angle closure disease. But when will lens extraction alone be not sufficient? I think there are at least two situations when you may have to consider additional interventions. Number one, when there is very advanced glaucomatous optic neuropathy necessitating a very low target intraocular pressure. And number two, if there is grossly uncontrolled intraocular pressure with very high IOP and or a very high dependence on glaucoma drugs. Now, so usually in a lot of cases, we may start off with phacoemulsification as the first line treatment for PAC-D. And if that is deemed not sufficient, we may consider combining it with another procedure. And finally, if we want maximum IOP lowering, we may combine phacoemulsification with trabeculectomy. You can see that when you move from left to right, there is increasing IOP reduction, as well as increasing surgical invasiveness, as well as surgical risk and time. Now, right in the middle ground, there are several different procedures you can combine with phacoemulsification, and I think different surgeons may have different preferences. But for I myself, very often I would consider combined phaco-endoscopic cyclophotocoagulation. Now, phaco-ECP allows a direct visualization of the ciliary processes by an anterior chamber endoscope. And under direct visualization, the laser is applied to the ciliary epithelium and thereby reducing aqueous humor production. You can see on the upper left-hand corner here that when you apply the laser, you're literally painting the ciliary epithelium white. And it is extremely important that you cover as much of the ciliary epithelium as possible during the procedure. And you have to cover all the surface of the ciliary processes as well as the valleys in between the ciliary processes in this procedure. Now, this is a randomized controlled trial conducted by our group that compare phacoemulsification alone versus combined phaco-ECP with a 24-month follow-up period. You can see that combined phaco-ECP does appear to offer a greater IOP reduction compared to phacoemulsification alone, even though at some of these time points, statistically significant differences may not have been reached. Now, this table here tries to compare the three surgical interventions that I mentioned in my own lens extraction treatment spectrum: phacoemulsification, phaco-ECP, and combined phacotrabeculectomy. Of course, this table is not entirely scientific because these data are derived from two separate randomized controlled trials, but this table does give you an idea how these three procedures compared. First, if you look at the IOP reduction, phacoemulsification reduces IOP by about 21%, phaco-ECP by almost 28%, while combined phacotrabeculectomy by almost 41%. If you look at the mean drug reduction at 2 years of follow-up, phacoemulsification reduced this by over 32%, phaco-ECP by over 48%, while phacotrabeculectomy by almost 84%. But then, of course, phacotrabeculectomy is associated with a greater risk of surgical complications, while in the phacoemulsification group, some of the eyes, roughly around 5% of the eyes, will require additional filtration surgery during the following 2 years of follow-up. Now, so how do you decide where in the treatment spectrum you should choose your intervention for a particular eye? I think, first of all, you have to consider how much IOP and or drug reduction is required for that particular eye. And secondly, you have to think and discuss with the patients how much surgical risk can the patient or you yourself accept for that particular eye. I think, of course, the final decision will have to be made after very thorough discussions of the pros, cons, and risk of each of these surgical options with the patient. Now, in the next part, I'll talk about the role of lens extraction in acute primary angle closure. Now, in the management of acute primary angle closure, there are usually two stages of treatment. In stage 1, we aim to reduce intraocular pressure fairly swiftly, and traditionally this has been achieved with drugs, but more recently, we have been using argon laser peripheral iridoplasty, while other centers have also used anterior chamber paracentesis or corneal indentation. Whereas in the second stage of treatment, we aim to prevent a recurrence of the acute primary angle closure, as well as to reduce the chance of progression to primary angle closure glaucoma. And traditionally, this has been achieved with laser peripheral iridotomy, but more recent studies demonstrated that actually early lens extraction can perhaps be even more effective and is very safe. Now, this is a randomized controlled trial we conducted in Hong Kong, comparing early phacoemulsification versus laser peripheral iridotomy in acute primary angle closure eyes. You can see that with early phacoemulsification, the proportion of eyes with raised intraocular pressure and requiring glaucoma medications at a mean 18-month of follow-up duration is significantly lower than those eyes treated with just laser peripheral iridotomy. So phacoemulsification alone seems to be a more effective treatment than laser peripheral iridotomy after aborting an acute attack of primary angle closure. Now, by widening the drainage angle, lens extraction may reduce PAS formation and also may reduce progression to PACG, and it may also be combined with syneculisis for even greater IOP control. So this diagram here summarizes our approach in APCA eyes in the year 2021. We start off with acute if we have a case of acute primary angle closure, we start off with immediate laser peripheral iridoplasty and as a first-line treatment. And once the pressure is controlled, the eye is less inflamed, then we proceed to early lens extraction. So thank you very much indeed for your time, and I wish all of you a very enjoyable and rewarding time in the rest of this APAO Congress. Thank you very much.
It is a great honor for me to participate in this year's APAO APGS Symposium on Angle Closure. I am Norman Aquino from the Philippines. For the next few minutes, I shall be talking about special considerations in the performance of trabeculectomy or traditional glaucoma filtration surgery in eyes with angle closure. I have no financial disclosures to make for this presentation. Angle closure comes about as a result of multiple complex and interrelated events involving the anterior structures of the eye. The iris, lens, ciliary body, anterior chamber angle, the zonules, the cornea, the choroid, and even the vitreous. The anatomic relationships among these structures form what is referred to as the static factors involved in the closure of an angle. Physiologic occurrences, like the changes in iris contour, area, and volume during pupillary dilatation, and the movement of the lens iris ciliary body complex, and the changes in choroidal volume are part of the physiologic or dynamic component of this particular disease. Any intervention to address angle closure will have to be planned with the following considerations. One has to determine, is the closure appositional or synechial? How much of the angle has already closed? How severe is the damage to the optic nerve and visual field? What is the patient's age and life expectancy? And of course, what are the socio-economic realities that exist in the healthcare delivery system of the community? All these should be taken into consideration when making a decision to treat. There are various modalities to resolve angle closure. Each modality aims to address the different pathophysiologic mechanisms involved in the development of this condition. For this talk, let us explore together trabeculectomy or traditional glaucoma filtration surgery. The accepted indications for the performance of a trabeculectomy in angle closure is very much the same as the indications for trabeculectomy in open angle. When the intraocular pressure remains uncontrolled and inappropriately elevated, when there is evidence of progression of anatomic closure of the angle despite previous intervention, when there is progression seen in the optic nerve and visual field, when there is poor and difficult compliance or intolerance to medication, and when there are economic barriers to prolonged medical treatment, then performing a procedure to enhance outflow and profoundly lower intraocular pressure is necessary. Here is a list of features that are common to eyes with or are predisposed to angle closure: short axial length, decreased anterior chamber depth, smaller corneal diameter, increased lens thickness, increased lens vault, anteriorly positioned lens, a narrow anterior chamber angle, a thick peripheral iris, loose zonules, and the anterior insertion of the ciliary body. The realization that angle closure eyes are different, together with the understanding of the mechanisms involved, will allow us to embark on a surgical plan that is destined to bring better outcomes. Preoperatively, it is imperative that intraocular pressure be lowered as best as one can. Operating on an eye with elevated intraocular pressure, as you all know, is perilous and is an invitation to disaster. Oral or systemic carbonic anhydrase inhibitors could be used in preparation of the eye for surgery. A careful paracentesis could be performed to adequately and slowly lower intraocular pressure at the start of surgery, thus increasing safety. Ideally, the eye for surgery should be quiet and have very minimal inflammation. Operating on the so-called hot eye will impact the success of surgery, as you know. Preoperative steroids can be given a few days prior to surgery. The trabeculectomy procedure for the angle closure eye is the same operation that we all have been trained to do. In doing filtering surgery in such eyes, however, there are very important details and tasks that we have to watch out for and do. Throughout the operation, the surgeon must make sure to control and stabilize the depth of the anterior chamber. This can be done by injecting viscoelastic or employing a chamber maintainer while doing all the intraocular and extraocular manipulations. Shallowing or flattening of the anterior chamber or instability in chamber depth at any point in the surgery can predispose the eye to unwanted complications like aqueous misdirection, choroidal separation, and even bleeding. Shallowing of the chamber can aggravate synechia formation and promote iris inflammation. To prevent these possible complications, you can leave the anterior chamber with an air bubble at the end of your procedure. Post-op, it is recommended that egress of aqueous through the scleral flap be titrated in order to avoid hypotomy and flattening of the anterior chamber. This is done with the placement of tight sutures, which can later be cut through suture lysis or release of releasable sutures if these were done post-op. Pharmacologic cycloplegia using atropine is given to help maintain anterior chamber depth post-op and to help rotate the ciliary body posteriorly. Aqueous misdirection or malignant glaucoma, as you know, commonly occurs post-op in these angle closure eyes. It therefore has to be watched very, very closely. Conditions that can lead to malignant glaucoma have to be addressed. Postoperative inflammation is a determinant for the success of any filtering surgery and must be monitored and controlled. In summary, attempts to address angle closure disease must take into consideration the multifactorial nature of the condition. Trabeculectomy still has an important and relevant role in decreasing the burden of angle closure disease, particularly in the Asia-Pacific region. Performing trabeculectomy in an eye with angle closure is oftentimes challenging, and it is important to do pre-op preparation, intra-op diligence, and post-op vigilance in all these angle closure eyes. Thank you very much.
Hi, Pring, are you ready?
Yes,
Yes, go ahead, please. Good to see you.
okay. Can you see the slide now?
Yes.
Okay, good. Sorry for the inconvenience. I'm Prince Rojanapuman. I'm very delighted to share with you a new surgical option for angle closure eyes. I have no financial interest to disclose for this any product or subject in this presentation. Basically, angle closure glaucoma is a surgical disease. So we need either laser or surgical intervention to correct the angle closure mechanisms. I'm talking about angle closure mechanism. There are non-pupillary block mechanism, especially the lens mechanism, that must be modified, correct, or removed once it's present. So in clinic, we can observe the lens mechanism by looking at the relationship between the lens position and then the iris position compared to the ACD and the cornea. And indeed, the lens component is really common factors. If we look into how to approach the surgical intervention for angle closure, then there are three schemes. One is to correct the angle closure by lens extraction, goniosynostosis, or cycloplasty, which is change the configuration of the ciliary process. The second one is to increase the aqueous drainage by doing trabeculectomy, trabeculotomy, minimally invasive glaucoma surgery like mixed, as well as GDD, the drainage device. And the third one is to reduce the aqueous production by endocyclophotocoagulation or ECP. I think lens extraction is a main part because lens factors or lens mechanism is a common mechanism in angle closure. And we can combine lens removal with other glaucoma procedure to make a combined option like phaco trabeculectomy, phaco GSL, phaco cycloplasty, phaco mix, phaco GDD, or phaco ECP, and phaco could be something else like coming on. But anytime we add any additional additional procedure to combine surgical options, we need to weigh again between the risk and benefit for any additional procedure because it will come with its efficacy and also complication as well. So basically, we're comparing between the phaco alone versus a combined procedure. We must consider additional complication, cost, time, number of patient visit, and also surgical expertise, which depends on surgeon preference and comfort. Let's start off with phaco versus combined phaco trap for angle closure. Krimantam in Hong Kong and his group looking at two prospective trials, looking at compare phaco versus combined surgery in medically controlled and medically uncontrolled patients. And what they found is that it works better in controlled IOP and reduced number of medication, but the complication is higher when compared to phaco alone. And this is easily understand because you add another procedure, you also add the complication of that procedure. And we all know that trabeculectomy has poor vision, high complication, very skill dependent, complex post-op care, and usually we keep it later. But Linda Hansa-Pino and Krimantam also have a follow-up on retrospective, look at that two prospective randomized control trial in to 5-year terms. And what they found is that phaco tabectomy was significantly more effective than phaco alone at 5 years. And it reduced the number of medication to less than 1 med per at 5 years. So although the complication is high, and you can see that 25 out of 28 complication is related to tabeculectomy. Because we add tabeculectomy, so we have more complication that related to the tabeculectomy, which is no surprise. But in essence, phaco trap is more effective and it's reduced the number of medication better at 5 years. If you're looking at a study that had 1 year follow-up, it may show that tabeculectomy did not seem to add any benefit, any additional effect on IOP. And that because of 5 years versus 1 year, that we could see things differently. Of course, there are many alternatives to tabeculectomy. There are meshwork bypass, there are juxtacanalicular tissue removal like MPFS, the shrimp canal stent, the filtration stent, the glaucoma drainage device, and also the psychodialysis procedure. And it belongs to, many of these belong to mix which have high safety profile, rapid recovery, and also acceptable efficacy and minimally trauma. So mix can apply to a different outflow channel like the tabecular outflow, the subconjunctival outflow, and suprachoroidal space. And they are different mix designed for different outflow channels, and as listed here. There are some that are familiar to Asia, some are not yet available in Asia. But to me, when I look at the mix in primary angle closure disease, it's actually a minimal invasive surgical options that can offer to the patient that once we widen the angle, we open up the angle, we can get access to that tabecular meshwork. It can bypass some of the compliance issue and also adverse event that from medication, and could restore some of the physiologic drainage. For example, if you look at the angle bypass of the eye stent, there are studies in this group that chosen and looking at a 1 year study, they found that combined eye stent implantation with cataract surgery was effective in lowering IOP, and the number of glaucoma medication at 12 months is quite favorable. Looking at a larger study, including 79 eyes per group, compare between phaco versus phaco 2 stent, and they found that this is a retrospective, but they found that the eye stent, the phaco eye stent group, which is 2 stent, show the lower IOP and lower medication when compared to phaco alone. I'm more familiar with the St-Gel stent, which is a subconjunctival drainage. So the St-Gel stent is a sigmal gelatin tube that connect the anterior chamber to the subconjunctival space. With the same phaco incision, we can introduce the injector into, and by ab-internal injection, we can do a subconjunctival drainage, which is a filtration surgery, similar to the tabeculectomy with a higher safety profile. Of course, the aqueous, the IOP reduction is not as good as trap, but the safety profile is much better. So to me, mix is options and potential, although there are limited publication, also lack of standardization and incomplete knowledge. But I just quickly go through this. But even in case that we don't have to do phaco, we can still have some good result for mix. And it offers a better post-op refraction stability. If I have to put in a toric IOL or multifocal IOL, I think if we do the filtering surgery, it does not offer that stable refraction. For example, this is a case that I do the phaco express and Ologen. And with MMC, you see a big blip at even at 18 months or 1.5 years. And if you look at the refractive data, the cylindrical keep changing all over the place from day 4, 3 weeks, 3 months, or 4 months, 1 year, and 1.5 years. Only after about 4 months, then we have a stable, but the refraction or the K reading change from that. So to me, there's a good potential of mix in primary angle closure disease. And if we're looking at a different clinical scenario that we have, in those who have cataract or not have cataract, IOP control with MET or not control with MET. In the past, we add more MET and perhaps end up with trabeculectomy. I think we can add mix in several of these scenarios safely. And in considering that, we have to look at the angle, the conjunctiva, the target IOP, how much lower we want to get, the visual outcomes, what lens we're going to put in, and the economic aspect of the patient as well. So there's a clear role of mix in and I think lots of potential, and although it's less effective in trap, but if we have a good case selection, then we can have a winning situation. Next, let's move on to the phaco alone versus phaco GSL or the corneal synchrolysis. And based on the 3 prospective randomized control trial study at 6 months and 1 year, you can see that there doesn't seem to have an extra benefit or clear benefit advantage of the GSL in over phaco. Next, if we can look at the phaco alone versus phaco ECP or endocycle photocoagulation, then we see that there's some suggestive evidence that ECP could be quite effective in lowering IOP, but it's come with its complication like decrease in predictability of the post-op refraction and also inflammation, like the earlier study like Morales that showed that the Freeman's reaction in AC and the absolute success is, although it's low, we don't know how long, how low the pressure could be. The other one is the phaco ECPL, which is the endocycloplasty. So this group has shown that with the endocycloplasty combined with phaco, they're able to get quite low IOP with fewer complications and also lower rate of intervention. Because of course, if you don't do filtering surgery, you cut off those many interventions that you have to do as post-op. But the total success of 90% versus 80% in phaco trap was not that significantly difference. So that's the table. And also another group looking at the phaco viscosynolysis with trabeculotomy, not trabeculectomy, also show that that could give a better result. I think if we want to combine anything to the eyes, we have to think of 3 things: contribution of the lens component, stage of the trabecular outflow, and the health of the optic nerve or the structural and functional damage. Identify and quantify lens component is not too bad. We can do that easily with the imaging device, or we can look at colonoscopy, looking at how much we can see the trabeculum, the ciliary bodies. But and identify and quantify structure and functional loss in glaucoma nowadays is not too bad. We can even tell the rate of change. But I think we still don't have a good way to identify the stage of trabecular outflow that will tell us if we remove the lens, how good the pressure lowering will be. So in summary, I share with you that lens removal modify angle configuration quite nicely and can reduce IOP. By adding another glaucoma procedure to phaco can help lowering IOP to lower, and then can help reducing the medication. Identify lens mechanism is very important. You have to be able to identify that before you can remove the lens. And IOP reduction is usually not that low, not enough if the eye has advanced stage. Phaco trabeculectomy still achieve lower IOP and need less anti-glaucoma medication, but with higher complication. And most complications are trabeculectomy related. Mix and phaco mix could be promising, and we just need more evidence and better case selection. IOP will be less effective than trabeculectomy or filtering surgery. GSL has questionable value, but ECP could be benefit with additional complication and cost. In general, most new surgical options for angle closure eyes are still lack of high level of evidence because the heterogeneity of the angle closure cases, subgroup, and follow-ups and criteria for success, we still not can suggest which one over the other one. But selective use can provide encouraging results. With that, thank you for your attention. I thank my fellow Patavi environment. Thank you.
Hi, thank you, Prem. Clem is there.
Yes, I'm here. Hello, thank you very much for your live presentation, Prin.
Should we start our discussion?
I think we have one question in Q&A box.
Please.
Okay, I'll read this one then. Sometimes we have challenges in lowering IOP with IOP lowering agents such as mannitol and diamox in some cataract and glaucoma patient. I'd like to know what is your opinion on in such challenging cataract and glaucoma case. So the question may be how do we lower the IOP in case of both cataract and glaucoma surgery case? Who can answer? Maybe Clement?
Yes, I'll be happy to start, but I must say I'm assuming that this is the most extreme nightmare angle closure situation. I must admit I don't have a good solution, but I'll share with you some ideas and how I would approach this. But of course, I would love to hear the views from the rest of the panel as well. So to start off with, I assume that this is a case of uncontrolled acute, more or less acute primary angle closure with very high pressure, and that laser peripheral iridotomy is not possible, and perhaps ALPI has been tried and the pressure is still high. The patient has been given mannitol and diamox and the pressure is still high, and I assume the anterior chamber must be extremely shallow. So I'm assuming that this is the extreme nightmare angle closure case that we have in hand. Now, I think the first step, if I believe there is still a significant component of pupillary block, I would seriously consider surgical iridectomy as a first step, because this is relatively safe, it is not too invasive, and if it does resolve the pupillary block and manage to lower the pressure, then afterwards, whatever you do, it will be much safer. So I think first of all, if there's any element of pupillary block, I'll probably start off with surgical iridectomy. If either surgical iridectomy is not successful, not possible, or does not resolve the pressure, then the next step down, I think it will probably have to be a combined phaco trabeculectomy. Now, first of all, if you just do the trabeculectomy and draining aqueous from the already very shallow anterior chamber, I think the risks are very high. On the other hand, considering the circumstances, if you just do phacoemulsification alone, I don't think that would be enough. So I think it would have to be a combined phacotrabeculectomy, but understandably, the risk is going to be extremely high. I would probably have a vitreoretinal surgeon standing by just in case. If the anterior chamber is too shallow for the phacoemulsification to be safely done, then I would consider a core pars plana vitrectomy to deepen the anterior chamber so that I can safely perform the phacoemulsification. And then after that, I'll add in the trabeculectomy as well. With all these possibilities and risk, I would seriously consider doing this under general anesthesia rather than regional or local anesthesia. So those are my initial thoughts, but I would like to hear from the experts here.
So Kehoe Park, do you have some experience for the extremely shallow anterior chamber with acute angle current glaucoma?
Sure. So I totally agree with the Clement's comment that so that situation is, even though we use diamox and mannitolization, the pressure is not controlled. So in those cases, surgical iridectomy is the simple and first step we can do, and then cataract surgery. And if there is any pressure in the inside the vitreous, we may get help from vitreoretinal surgeon for the co-vitrectomy or vitreous tap or something like that.
Yeah, me too. We also, for this extremely shallow anterior chamber, we will do the vitrectomy, just get some vitreous, get the vitreous pressure down and make surgery more easier. Yeah.
Maybe I can just add one more point. I mean, in cases that are this extreme, I think when you perform the phacoemulsification, you might consider combining that with a surgical iridectomy and a sonolectomy, and also disruption of the anterior hyaloid face, because there's a big possibility that there's a component of malignant glaucoma there as well.
Yeah.
What
Recently, we one paper just published on the eye, the journal Eye. For these kind of cases, we sometimes do the before the operation, we do the photo calculation, and then can make the chamber deeper and make your surgery easier. Yeah, that is another options for the acute angle current glaucoma.
Whenever I am faced with the situation wherein I am already about to start the operation, and yet the tension of the eyeball is still too elevated for comfort, what I generally would try to attempt to do is use a gauge 30 needle, do a slow paracentesis, let the aqueous ooze as I slowly withdraw the needle. And usually that allows me to lower the pressure, I'd like to think safely, low enough for me to proceed with my operation. So, it's either I use a gauge 30 or I use a stiletto knife as I do my primary port for the operation. And that usually is a big help.
All right.
I think we have a second question here, but we only have 1 minute left. The question is in the chat box. I would like to ask in patients with chronic angle closure post-laser PI where the angle is still closed and there are already presence of PAS due to inflammation from acute attack and laser. However, there's still ocular hypertension. What surgery would be the next best step of treatment? Anyone can offer a quick answer? Maybe I can refer back to one of my slides. In fact, I presented an algorithm. In my talk, I was saying that if there is visually significant cataract, then do the cataract, do the phaco, plus or minus another IOP lowering procedure. But if there's no cataract, then you would have to decide whether the lens is the main mechanism. If so, then you may consider lens extraction with possibly another IOP lowering procedure. But if the lens is not considered a main mechanism, then just one of those IOP lowering procedures. So I think that would have to conclude our talk today. Perhaps, Ning Lee, you have any concluding remarks?
Yeah, thank you every speakers to give us a very good presentation here, and also thanks our audience. Actually, on our chat box, there is many questions. So we have the time to answer. We can collect the questions. And for the next, if in the future we have the opportunity to answer the questions from the audience. Thank you, the secretariat teams make the arrangement for our sections. Thank you. Thank you very much.
Thank you.
Thank
you so much indeed.
Thank you.
But let me just call on everyone, please do not sign off now, because coming up next is something perhaps even more interesting and exciting as angle closure glaucoma. Okay. What we're going to have next is the 60th APAO 60th anniversary birthday song performed by a large group of ophthalmologists from our region. And it was organized and led by Professor Rita Sitoris. So please do stay behind and we'll sing this birthday song together.
Okay. Oh, yeah.
Happy birthday to you.
Happy birthday to you.
Happy birthday, happy birthday, happy birthday to you.
Happy birthday to you.
Happy birthday to you. Happy birthday, happy birthday, happy birthday to you. Happy birthday. Selamat hari jadi Piradana Watuga Jolly Sally I love Selamat ulang tahun Selamat hari jadi Piradana Watuga Jolly Sally quite low Happy birthday to you Happy birthday to you Happy birthday, happy birthday Happy birthday to you Happy birthday to you Happy birthday to you Happy birthday, happy birthday Happy birthday to you Happy birthday, happy birthday Happy birthday to you
Happy birthday to APAO.
Happy birthday Happy birthday
Happy birthday to you.
Happy birthday to you.
Happy birthday, happy birthday, happy birthday to you.
Happy birthday to you.
Happy birthday to you. Happy birthday, happy birthday, happy birthday to you. Happy birthday. Selamat ulang tahun. Selamat hari jadi. Piradana Watuga. Jolly Sally, quite long. Selamat ulang tahun. Selamat hari jadi. Piradana Watuga. Jolly Sally, quite long. Happy birthday to you. Happy birthday to you. Happy birthday, happy birthday, happy birthday to you. Happy birthday to you. Happy birthday to you. Happy birthday, happy birthday, happy birthday to you. Happy birthday, happy birthday, happy birthday to you.
Happy birthday to APAO.
Happy birthday. Happy birthday.
Okay. Bye, everyone. Good night.
Yes, bye-bye. Bye-bye, Sen Kyung.
Bye.
Bye-bye, Ning Li. Bye-bye, Kiho. Bye-bye, Prin.
Bye.
Yes, and good night.
Good night.
See you all tomorrow.
Yep.